So the idea today was to talk with you about the mechanism behind scleroderma, to explain you the process of the disease so you could understand better why we use such or such treatment and how the research works about scleroderma and how we try to find new treatment for this disease and the way we think as researcher about scleroderma. So the outline for this evening is for to understand the mechanism behind the disease, to have some example of the mechanism of action of different treatments, and also to answer key frequent questions and to answer specific questions you would have about the disease. So pardon my French, you can interrupt anytime if there is something that is unclear or that you have not understood. And you can really just interrupt anytime. I will be really happy to answer any questions about the disease process and scleroderma and the mechanism of the disease. So first, understanding the mechanisms behind the disease. So scleroderma is a disease due to a non-adapted communication between the cells of our body. So first, what is a cell? So our body is composed of organs, for example, here a hand, and the different part of an organ, the different layers of an organ is called the tissues. For example, in hand you have the bone, the muscle tissue, the skin tissues, which compose the different organs of our body. And the different tissues are composed of cells. So cells are little particles that together are responsible for the tissues. And these cells that you can see here, we have different types of cells in a single tissues. And these cells, they work together as exactly would work in a living city. So this is why I like to highlight that our body works as a living city, which is mean that there is constriction work all the time. So if you are young, these constriction works helps you to grow up. And if you are old, well, this help you to get older in some way and to age through time. So when I mean constriction work, what does that mean? That means that we have construction workers that use bricks to create new roads, new buildings. That means that you have an automobile traffic and a circulation. And that means also that you will have policemen or traffic control officer that help everything to work together. So if we want a city to continue to work properly during construction working, you need to have communication between all these players at stake here. So you will have traffic signs, so the construction workers could explain what they're doing to the drivers, the automobile traffic. You will have the policemen who will have their own way of communicating with the drivers, if you know what I mean. But you will also have the traffic control officer that will help the constructor to be understood and that will prevent any issue with the drivers. And the drivers will also have their own communication systems. And some of them are quite specific or particular, if you know what I mean. So technically, our body works exactly the same way. In a normal body, you won't have policemen, but you will have an immune system which is useful to defend you against viruses or bacteria, but who will also participate to the communication in our body, exactly like an office control officer would do, a traffic control officer would do. You don't have constriction workers, but you have the equivalent, which are called fibroblasts, and they don't use bricks to construct new tissue, but they use collagen fibers, or what we call extracellular matrix, which are technically like bricks. And they use these bricks to make our tissue, our organs stiffer and to shape our organs. And you also have a vascular system which works like circulation in some way. This is also a traffic system. So exactly as the construction workers or the policeman uses signs to communicate within each other, the different cells of our body also use messages to communicate so everything would work together. So exactly like I said with the policemen or the construction workers and the traffic signs. And these messages in our body are called the cytokines or the interleukins or the growth factors. We don't care about the names, but this is just to give you the scientific names of the messages that our cells use to communicate to each other. And each cell also have a system of mailbox to receive the messages. And these mailbox are called the receptors. And to be more specific, there are plenty of mailboxes or plenty of receptors on each cells, and each mailbox is supposed to receive a specific message. So this is really technically how our body works in a normal condition. And there are different types of message. The message from the immune system are called the inflammatory or the inflammation message. And for example, you have IL-6, which is one of the message that is delivered by the immune system. You also have what we call the constriction message, which are called the fibrotic message. That could activate or be produced by the fibroblasts, which are the constriction workers of our body. And you also have vascular messages, for example, endothelium, that can activate the vascular system and that can participate to a good or sometimes a bad circulation. So these are the key messages that are useful for our body to adapt to its environment in a normal condition, but also to grow up when you're young or to age when you're older. So these are normal messages, and this is really how our body works. So what's wrong in scleroderma and what's happening in a scleroderma patient? Where technically during scleroderma, there are too many messages or they are wrong messages. So this is the base of what we call the pathogenesis of the disease, meaning the mechanism of the disease, that there are too many messages. So there could be too many messages of fibrosis, for example, the PDGF, which is one of these messages, or there could be two messages of inflammation, for example, IL-6, but also autoantibodies that are messages from the immune system. And there could also be too many vascular messages. And here you can understand that depending on the messages that are in excess, you will have different manifestations of the disease. There will be fibrotic manifestations due to the fibrotic messages. There will be inflammatory manifestations due to the inflammation messages, and there will be a vascular manifestation due to the vascular messages. So what are the concepts behind the research on scleroderma? So one first aspect is the identification of the messages that are wrong or that are in excess, and eventually to understand what triggers them. Okay. The other aspect is to understand how we can block these messages, meaning how can we find new targeted therapies that could block the message. In other way, we need to identify the message and to block the receptor, meaning the mailboxes that are supposed to receive these messages, to block the abnormal or the messages that are in excess in our body during scleroderma. So you've may heard that there is heterogeneity in the disease. And with this concept map, you may understand now that some patients will have, for example, too many fibrotic messages, and then they will have the manifestation of the disease associated with these fibrotic messages, for example, pulmonary fibrosis or diffuse skin involvement. But there could be patients with more inflammatory messages, and these patients will have, for example, joint inflammation, more specifically, or inflammation in the muscles, what we call inflammatory myopathy. And some patients will have more in excess, vascular messages in excess, and they will develop more severe vascular manifestation of the disease, such as digital ulcers. So with these, and in some, unfortunately, in some patients, you will have an excess of all of these messages together at the same time. So with this, you understand why we said that there is a high heterogeneity in scleroderma, depending on the messages that are in excess. And this will explain you why some patients will have such manifestations, whereas others will have other types of manifestation of the disease, depending on the message that are in excess. So this is why I like to say that each patient has his or her own scleroderma, depending on the message in excess, and that each patient has his or her own treatment, depending again of these message, because the treatment will target a specific message and will block this message. And for example, here you will have, for example, the tocilizumab that is supposed to block IL-6 that will be useful to block inflammation, for example, or CellCept that has anti-fibrotic properties and anti-inflammatory properties, which will be useful in patients with either fibrotic or inflammatory manifestation of the disease. Or, for example, you will have sildenafil that can block vascular messages to help circulation, and that will be useful in patients with more severe vascular manifestation of the disease. And another example would be the nintedanib that block specific receptors linked to fibrotic messages. But here you understand, if a patient has no excess of inflammation or inflammatory messages, you don't need to use anti-inflammatory drugs. Or on the contrary, if a patient doesn't have vascular messages in excess, you don't need to block these vascular messages. And this will explain why some patients have specific treatment that others won't have, and why we consider the disease as being very heterogeneous. So what's the concept behind Scleroderma research based on these concept? Well, the idea with research is to link the messages with their receptors and to identify which messages are responsible for which symptoms of the disease. For example, which manifestations are responsible for the fibrotic manifestation of the disease, which messages are responsible for the inflammatory manifestation of the disease, etc., and again for vascular. So if you look at this from a scientific viewpoint, this is an example of an article, a research article, that as you can see, this is not very different from the scheme and the sketch that I've just shown you. These are the different types of cells. These are the different messages and the connection or the communication between the different cells and the different messages. And we try to identify and to connect these messages to know which one we should target to efficiently block the messages that are responsible for specific manifestation of the disease. But for that, what do we need? We need to understand which message drives which manifestation of the disease. This means that we need what we could call biorepository. What does that mean? A biorepository is a biobank of different tissue sample or immune cells that will help us to understand the link between some manifestation with some messages. And for that, we need to have the global picture of the disease, meaning a lot of patients with different type of manifestation to understand the different messages these patients have in excess and to link these specific messages to their specific manifestation of the disease. So this is why we could say that our body works as a living city, and that in scleroderma, too many messages lead to dysregulation of the normal process, meaning an excess of fibrotic or constriction messages, which leads to fibrosis, an excess of vascular manifestations, messages, which leads to vascular manifestations such as Raynaud's phenomenon, or an excess of inflammatory manifestations such as, an excess of inflammatory messages that leads to inflammatory manifestation of the disease, such as joint involvement. So what are also the frequent questions about scleroderma? So first of all, is scleroderma a genetic disease? So the first answer and simple answer would be no. And why is that? Because if you take two twins, which are genetically identical, what we know is that when one twin has scleroderma, the other twin, in most of the cases, won't have scleroderma, which is the demonstration that technically this is not a genetic disease. Because if it was only genetically driven, then two twins would have definitely each time both of them the disease, which is not the case. But, and there is a but, we know that there is a higher risk for family member of someone who has a scleroderma. There is a higher risk for their family members to have not scleroderma, but an autoimmune disease. This is definitely not systematic, and this is definitely extremely rare, but we know that there is a little higher risk of having an autoimmune disease when someone has an autoimmune disease in the family. Another question is, what is the cause of scleroderma? In other words, what would trigger the excess of messages? Well, if you go back to the idea that this is a very heterogeneous disease and that some patients have an excess of certain types of messages, whereas other patients don't have these messages, you can understand that there is not probably a single cause of the disease, but there could be multiple causes, and that in patient who has, for example, an excess of inflammatory messages, the cause of the disease may not be the same as in patient who has, for example, more important vascular manifestation of the disease. And this is probably the reason why it is hard to find a single cause of the disease, because this is a very heterogeneous disease, and depending on the clinical presentation, maybe the cause of the disease is different. So this would be my conclusion, hoping that I've helped you to more specifically understand the concept of this disease based on these different messages, and that will help you to understand why you may have one treatment and someone else that you know doesn't have the same treatment, because this is due to the different messages that are behind the disease and its heterogeneity. So I'm totally open to any kind of question about what I've just said and about the pathogenesis or the mechanisms behind scleroderma.
I see, Sherry, is that your actual hand up? I like it. Sherry's using her hand raising. I will ask you to ask your question.
Thank you. So I'm going to say Dr. Lescoat, and really it's Dr. Lescoat, right? Is that close?
Some kind, yeah.
First of all, thank you for that, because I think that's really interesting. But to ask my question, can you throw back up the screen, that last wrap-up screen that had all the message boxes? Okay, right there. So can I just make sure I have this right?
Yeah.
Because I was told once upon a time there's never a dumb question. So, okay. The reason that, in my body, and I'll just use Nadia as an example. So Nadia and I both have scleroderma, but the amount of messages in our, system here, or maybe the type of messages that we're getting in our bodies are different. Yep. So let's say I have inflammation in my fingers, in my joints, and I have really bad Raynaud's and digital ulcers, and I have some fibrosis in my esophagus. Let's just say that. And let's say Nadia has heart issues and pulmonary hypertension, just for the ease of it. So in my system, my immune system, the inflammation part of it, so let's say my receptors are getting flooded out, and that's why I have, let's say, the hardening of the fingers. But in Nadia's case, her lungs are becoming fibrotic because she also has pulmonary hypertension. So these receptors in her mailboxes are getting different coded signals than mine are for my esophagus, let's say. Is that kind of, am I on the right?
Yes, Sherry, this is exactly the idea. To be more precise, the pulmonary hypertension is due to vascular messages, to be correct. So yes, and so that's the reason why we would use treatment targeting vascular messages during pulmonary hypertension, whereas for example, joint involvement, which are due to inflammation, we would not use these kind of treatment because that wouldn't help for a joint involvement. Yes, this is exactly the concept, precisely.
Thank you.
Does anyone else have a hand up? Sorry, I wasn't. I got
Nadia,
lost.
I have a question.
Yeah, okay, go ahead.
Go for it.
Doctor, where is the biorepository? How are they going to collect the samples to store and then study?
Well, I think I'm not responsible for the biorepository, so I don't know exactly how they're gonna do it, but they technically, they take, for example, a little skin sample, a very small skin sample, or white blood cells from the blood, and they can store that at the U of M in a huge fridge, which is technically exactly what they will do. And then they can look at the different messages in the tissue and link that to the clinical manifestation that you have. For example, if you have lung involvement or vascular involvement, and make the connection between the messages that are in your tissues and the clinical manifestation of your disease.
May I continue? I have one other question about that. So, like many of you, I think, I have given Dr. Khanna all sorts of samples, but as scleroderma keeps mutating, it seems, and evolving as time goes on, do those samples become outdated as they are stored? But as your symptoms change, should new samples be necessary to study?
Yes, that's an excellent question. And yes, definitely, that could be an idea, that we could look at the messages that are here at the beginning of the disease that may be different at the end of the disease. This is also the reason why you may have heard that sometimes we use treatment only for early scleroderma and not for late scleroderma. And on the contrary, that some manifestation of the disease occur more lately during the disease process and not early during the disease process. And this is definitely, you're definitely right. Some messages are associated with the early disease, whereas other messages are associated with the more late stage of the disease. Definitely. This is a great question. Yeah.
Thank you.
My question is, are we researching and do we know anything about what are the triggers for the dysregulation that occurs in scleroderma? And is there research going on so that, you know, we can abate the disease earlier?
So yes, as I have tried to explain, there are probably different types of triggers. So we won't have a single answer to that, and we won't. I'm convinced that we won't be able to say that there is one cause of the disease, but there is probably different causes, and this explains the heterogeneity of the disease. But for example, in some men, and I say only some men, we know that the exposure to stone dust, which is called silica, for example, can trigger the immune system, and this may participate to the inflammatory messages, and maybe this is one of the triggers. But for example, in men only, and that would not work in women, because we know that the disease may be different between men and women, for example. And you also know that there is what we call autoantibodies, and autoantibodies are messages from the inflammation from the immune system. And there are different types of autoantibodies in different patients, and they're not the same depending on the type of the disease, if you like. And probably there are different causes depending on the different autoantibodies. And if you have certain type of autoantibodies, you will have maybe a certain type of cause. Whereas if you have another type of autoantibodies, the causes are going to be different. So yes, definitely we are working on that. We are working on these questions. Yeah.
Thank you.
I have a question for Dr. Lescoat. When something gets triggered, And it could be in the inflammation. I'm looking at your chart here, the fibrotic, the vascular. Could it get triggered all at once? Or does one thing get triggered and then the next thing and the next thing? Or
Well, yeah, thank you for your question, Mary. What we think is more, like you said, more sequential process, one after the other. Yeah. Well, in what we call the limited form of the disease, we think that the vascular messages are the first one, probably, and then the inflammation, and then more lately the fibrotic messages. Whereas in the diffuse scleroderma, we think that the inflammation may be the first one, or at least very close to the vascular messages, and then the fibrosis occurred. But this is definitely more something like one after the other than all of at the same time. But in some patient, in more severe patient, I would say this is all at the same time. And yeah, it depends on each patient.
so somebody could have, and they do have it all at the same time. Like you have, it would affect all three systems,
Yeah.
all three.
Yeah.
Okay.
So in most of the patients, all the three systems are affected, but they are more or less affected. If you know, there are some patients, there is a little bit of inflammation, a little bit of vascular message, but a lot of fibrotic messages. And whereas in other patients, there is very little fibrotic messages, a lot of vascular messages, and a little bit of inflammation. This explains you the very complex mosaic or heterogeneity of the disease. But in all patients, there is a little bit of each of messages, but in some patients, there are some of these messages which are really in excess. And this explains why some of fibrotic manifestation or other more vascular manifestation or inflammatory manifestation. Yeah.
Okay, thanks.
Terrence, I'm going to throw you the last question, and then we're going to wrap it up. So
To get this
bring us
out
home.
before I forgot. It's a two-parter. So what you were saying is that this condition, like, is not genetic, and I'm trying to understand that because when I was talking to I remember one of the doctors I was talking to in the beginning, and I worked for Ford, and they asked me about all the chemicals I had come in contact with. And I told them about all these chemicals, and all of a sudden it just got quiet. And nobody else said anything, but then I was always led to believe. Then the next things they always were asking me was about who in my family had this condition. And no one in my family that I know of, and I went back 3 generations, has had it. I'm the first. So, but we've had other autoimmune things in the family. So that's what I'm saying. So what I'm coming to understand is that just because you have when you have an autoimmune issue, it could trigger. It doesn't necessarily mean you guys are all going to have the same autoimmune. It means that you're susceptible to all sorts of autoimmunes. Is that what I'm trying to understand?
Yes, and yes, that's true, but this is only being susceptible. That means that in most of the case, for example, your kid or your grandkid or grandchildren in the vast majority of the case, they won't have an autoimmune disease. This is definitely not genetic. But what we think is that, for example, what is genetic? This is actually what will define the type of receptor, for example, that you have. And if there is something that will trigger some messages, and that in a genetic background, you don't have the receptor for these messages, then you won't have any problem. But on the contrary, if on your genetic background, you have these receptor and you will have the same trigger, then maybe you will have the disease. You know what I mean? This is a crosstalk between the genetic susceptibility, for example, the type of receptors, and the environmental trigger, for example, being exposed to silica and sort of thing. Because on the contrary, there are people that are exposed to silica and they will never have scleroderma. So it means that you need both the genetic and the triggering factor.
So it's the two-parter.
Absolutely.
There it is. Okay, now I understand. Okay, thank you.
You're welcome.
I want to very much thank our very own unicorn having specialist, Dr. Alain, for being here tonight. Thank you so much for presenting this. This was very helpful and very interesting. And I'm glad that you were able to be in Michigan during construction season to get all of those great pictures of things being fixed, because they say it every year, but they're fixing the same thing every year. So I'm glad that you were able to get those pictures for the presentation. Thank you so much for being here. If you guys have additional questions that you did not get answered, or you want to reach out, you can reach out to any one of us, and we will make sure to get those questions to our specialist. So one more time, thank you so much for putting your applause in. If you all would like to give a round of applause. We appreciate you very much for being here today. Guys, May is coming up. April showers, May flowers. We tried that earlier. It's snowing. I'm sorry. We are not going to have an event next month. I know that part is sad. Everybody can go, oh, no, right? We want you guys to go outside, be outside in the fresh air, hug your grandkids, have a good time next month. So we won't have a social event next month. However, in June for Scleroderma Awareness Month, did you know we have a month? We have our own. It's June. So for Scleroderma Awareness Month, we are going to have some sort of social activity. Mark your calendars for June 8th. You'll get the information for June 8th. We're not sure what's going to happen yet. However, if you want to be a part of the planning, we welcome people for planning. If you have an idea for an activity or something you'd like to do, or something you think that would be fun, if you've got a quirky activity or even a corny activity, we welcome quirky and corny. We will take all of those suggestions. Let us know, but look for more information for our June 8th get together. Now, that doesn't mean that the mentors are going to get off the hook for May. We are looking to put together a mentor meeting for May, because there's some information we'd like to pass on as we try to get our handbook together and try to get our best practices together. So be on the lookout for that too. Now, one last announcement, because I know we're going to be respectful of time and everybody's bopping out, but I want to make sure, because this is really super important. A lot of the things that we do are research-based, because we are trying to find a way to beat the disease, and the way to beat it is with science. And so our very own Dr. Susan Murphy and our very own Dr. Yed, everybody wait for the cameras. Their stories are different, and you will have to come back to their presentations to hear about their unicorns. But Yen is going to tell us about the brain fog study and give us an opportunity to sign up if we're interested. So go ahead and take it away.
Hello, everyone. So I'm Yen. So I'm working with Dr. Susan Murphy. So the reason that Dr. Susan Murphy and I are started this brain fog project is because we often hear people with scleroderma saying that they have experienced brain fog, like Sherry just did, right? So they forget about things easily, and then it's hard for them to focus. But there is not much research out there that examining brain fog in scleroderma. So that's why we wanted to conduct this study to see how people with scleroderma describe brain fog and how brain fog affect their daily life. So this would help us develop better treatments, and then come up with better self-management programs that improve quality of life among scleroderma patients. So I create this QR code. So if you can grab your phone and then turn on your camera and just trying to take a picture of this QR code, and then it will pop out a link. So you can then leave your contact information, like your name and email and phone number, and we will contact you. So that would be easy for you to sign up. So this study will involve one online survey. You will spend about 15 minutes to complete a survey, and then you will be joining a virtual group discussion via Zoom. That would be an hour.
I guess now that we're just shamelessly plugging things, I will also say that we have a registry that we also have, Yen helped us put together something with a QR code as well and a link. And the registry is called the Sclero Rehab Registry. Mary will be posting something similar to what you see here in the backers Facebook group. And we'll also, we can send it to you as well. If you haven't signed up, it's a way for us to contact you about studies that you can participate in. Many don't require travel to the university, and there are focus groups and surveys, and we're doing some interventions that are remote. So you may be interested. It doesn't obligate you you don't have to do what we ask. We just will share opportunities with you. And if you want to hear more about it, oh, thank you. There it is. So there's the other one. So we can also share this with you in other ways, but it has the QR code in the same way that it will take you to where you can sign up for that. So it just allows us to store your name and email and a little bit about your diagnosis, so we can call you or email you with any opportunities that come up.
We have come to the end of the things on my outline and on my agenda. Thank you all very much for coming. On the lookout for the stuff coming out in June. And anybody who needs to stay for anything, just like hang out here for a second. We'll wrap it up from there.